Good morning, everyone, and thank you for joining us for the first installment of the 2020 KSHE Weekly COVID-19 Forum. We appreciate you being here and taking part in what we hope to be is an incredibly informative installment. We'd like to thank today's sponsor, Harshaw Train, who has devoted some support to this webinar today. Next slide. So Harshaw Train, we've got some contact information for some of their contacts if you need anything from Harshaw Train. In the meantime, let's go over some housekeeping matters before we kick off today. You may have noticed as you entered the webinar that you are muted. This is to preserve the sound quality of the recording. If at any point during the webinar you do have a question that you would like to ask our panelists, you can use the Q&A feature to type in that question. If you don't see the Q&A feature on your screen, go ahead and hover your mouse over the center of your screen. You should see the Q&A button pop up on a toolbar either at the top or bottom. You can click that button and your Q&A window will appear where you can ask your questions. We do ask that you keep questions to the Q&A box and not the chat box, as they can get lost in the chat. We will be posting a recording of this webinar after on our website, so keep an eye out for that if you'd like to share this information with anyone in your department or anyone you know that could use it. So with that, I'd like to go ahead and introduce the 2020 KSHE President, Mr. Joe Taylor.
Well, greetings, everybody. Emma, can you all hear me okay?
Sound good to me, Joe.
All right, great. Well, greetings, Kentucky, and thanks for joining. I also want to thank KSHE's good friends at Harshaw Train for sponsoring our first weekly COVID-19 forum. Your dues and Harshaw Train sponsorship permits us to offer this type of first-class content to all of the Commonwealth and beyond, and we're very excited for their participation. I also want to thank our friends and partners at the Kentucky Hospital Association and the entire panel for participating today. Everyone is certainly very, very busy, but making the time to disseminate the latest information about COVID is critical. And we're blessed to know that the KHA and others truly have our backs. The two photographs you see on your screen are examples of the different hats our facilities engineers have to wear each and every day. Some days we might be an executive making a presentation to the hospital board, and on other days we might be designing and fabricating face shields to supplement a scarce supply of essential PPE for our clinical-facing caregivers. Well, today we hope to give you some valuable information to help you manage your COVID-19 hat. That would be the picture on the right. With that, I'm going to turn the program over to our KSHE Education Vice President, our friend, and today's moderator, Mike Canales. Mike?
Yeah, thank you, Joe. I appreciate that. And again, I appreciate everybody here today. I appreciate our experts. I appreciate Harshaw Train. I think that's one thing that marks this time. It's just a lot of appreciation for all the efforts that everyone's doing. My goal today is to keep us on track and to move this presentation along to provide you the utmost possible quality information in a timely manner to respect your time, because we know how busy you are. We're going to open up with Deb Campbell, and she has some slides to present. Deb, it's yours.
Thank you, and thank you for inviting me to be here today. I got some particular questions from the folks to answer, so if there's anything else that you want to ask me, I know there's time for questions later on. Next slide. So these are the numbers as of yesterday, and before I go over them, I just want to say everyone needs to always be aware, really, no matter where you're getting your data on COVID-19, it is quite imprecise as a general rule. There are issues with data lag, there are issues with redundancies that are later corrected. So you may look at 3 different places and 3 different numbers, but this will give you an idea. So as of yesterday, we had 204 new cases in Kentucky for a total of 1,346. We've had a total of 71 deaths. We have tested 21,620 people, and please remember this is definitely an underestimate. These are just those that have been confirmed. And the recovered total of 339 we know is way underestimated, because we know very, very many people have probably had this virus, have either been asymptomatic or mildly symptomatic, and have not met the criteria to be tested, so they're not even on our radar, and yet are probably completely recovered. So just some things to think about when you look at these numbers. In the U.S., you see the total as of yesterday, 435,000 cases with 14,622 deaths and over 2 million tests done. This recovered number is, of course, also a big underestimate. Next slide. I also received a question from some of your folks about worker quarantine versus isolation. So I just wanted to go over this with the group. Quarantine relates to a person who's been exposed but is not ill. That quarantine after exposure, according to the CDC, is 14 days. I'm going to tell you about the exceptions. But the first thing I want to say is that what constitutes an exposure has been quite confusing. So right now it is defined as being within 6 feet of a COVID positive person for a prolonged period of time without appropriate PPE. And they've called prolonged period of time as greater than a few minutes. So it's, again, very imprecise. And a lot of this is up to the clinical judgment of the folks at the level of facilities. There is an exception for essential healthcare workers. My assumption would be that our engineers would be essential healthcare workers, and we need to follow that guidance. And for those essential healthcare workers, if there is an exposure, but the person is asymptomatic, they can be allowed to work. And it's up to the facility whether they would have them wear a mask and what the screening process would be. But at the very minimum, the person should be looking at their respiratory symptoms and their temperature every day before going to work, and then wearing a mask if their hospital requires them to do so. So I know that's a little bit in the weeds, but I thought it was important because I know you guys are probably making decisions about who can come back to work. Isolation is a different thing. Isolation is when someone is ill. So this is a COVID positive person or a person who is symptomatic and is under investigation for COVID-19. They can return to work when they have been without fever for 72 hours, their symptoms are resolving, and it's been at least 7 days since symptom onset. I put the link here so that if you want to update your guidance as time goes on, because it changes. This is the most rapidly evolving situation I've ever been in. I tell people what I tell you today may or may not be right this afternoon. So that's why the link is there, because that is kept updated. Next slide.
Just 1 second here.
Thank you. So another question that has come to me is about decontamination of PPE. So I just wanted to say, CDC continues to say, please use conservation strategies before considering decontamination, because I know folks are getting questions at their facilities about this. Best practice is still considered to use extended wear of PPE, particularly masks we're talking about here, of course. And reusing the mask by the same healthcare worker. And there are very specific guidelines around that on the CDC website. If anyone would like that, I'd be happy to share that with you, and you could send it out to the members. But if crisis strategies end up having to be employed, the CDC most recent guidance is to focus on 3 methods for decontamination of masks, and that is the ultraviolet germicidal irradiation, vaporous hydrogen peroxide, or moist heat. There are a lot of other rumors flying around about dry heat. I shouldn't say rumors, but kind of reports about dry heat and liquid hydrogen peroxide, things like that. But for now, the most data is available to us around these 3 measures. Having said that, it's really important to recognize that there are very, very specific guidelines around even these 3. For those of you who have not looked at this yet, the moist heat requires a particular temperature, particular relative humidity. The ultraviolet, a certain dosage for certain periods of time. And hydrogen peroxide has similarly very specific guidelines around it that would these are outside of my time window, but I do have those things available, again, if anyone's interested in them. The other thing I would say is that the reason that these are considered crisis strategies is not because anyone believes that one or more of these couldn't work to disinfect the mask. It's the process involved is so involved, and the opportunity for recontamination is so great in the increased handling. And then we don't also know what it does to the straps and to the fit as well as we might if we had more time to do research on this. Again, encouraging our facilities to look at conservation strategies first before they work on decontamination. Next slide. And then I just thought this was an interesting slide that came to my attention this morning. You can see where the information came from there from the Department of Public Health, and this is a comparison of Kentucky to Tennessee. And when you see this slide, and I know it's kind of out there, so I just wanted to share that it may show that indeed Kentucky's very aggressive approach to social distancing and other such initiatives may have put us in much better stead than Tennessee, where they were not so aggressive. The other thing to note about this when you see comparisons in all of the places that we get to see graphs is that Tennessee has a larger population than Kentucky, and they're also doing a lot more testing. So while I do believe there's probably a significant difference, there are some caveats when we look at these slides. So I just thought people might be interested in that. Next slide, please. Again, I really have been encouraging people to try to avoid sending out a lot of documents with information, instead to send links to people, because these things are updated so frequently. So I put a few sites on here that I thought might be helpful that are relative to engineering controls. If there are other things that your members are looking for that you're having difficulty finding, I'd be happy to help you research that. I may have more time than some of you to do that while you're busy in your hospitals, your facilities. Thank you, and again, I will try to hold on as long as I can for questions. I do have another call later, but I'll try to stay on as long as I can.
Thank you, Debbie. We really appreciate that information. And just in case you're wondering, we do plan to send out the slide deck afterwards. We're going to just double check with all the presenters before we do that, but it is our expectation we'll be sending you the slide decks. The next speaker is Dick Bartlett from the KHA Emergency Preparedness Trauma Coordinator. And Dick, go ahead, it's yours.
Thanks, folks. Got 3 slides to go over with you here. Won't take a lot of time. First slide, go ahead and advance it one, Emma. Is one that information that came to me yesterday from our Customs and Border Patrol office here in Louisville. We have something in Louisville called our Crisis Management Group, which brings together all of our law enforcement and public safety partners, and these folks are included in that group. And he called me up because they've noticed a huge number of counterfeit 3M N95s masks are beginning to show up coming through the system here, and they were concerned because it's such a large amount that 3M actually has set up a website to help you validate the authenticity of their masks if you're concerned about whether or not it's a legitimate N95 from 3M. And actually, while it's a little hard to see under the word 3M, there's actually a little number down in there. It starts out with some characters and then goes on. That number, you could actually take that mask model, the 8210, and go in there and put that authenticity number on there, and it'll come back and tell you whether it's a real mask or not from 3M. So I thought I would share that. And if you do run into things that are obviously counterfeit, because we're getting an awful lot of stuff coming in here from other countries right now, there's a link that they've provided, I got up there on the screen, where you can actually go and report something that's counterfeit. Come to find out that Customs and Border Patrol is also involved in patent enforcement and other issues as it involves things that are made and brought into the United States. So they're more than willing to get involved in that you can go in and look at that site and take a look at it and see if you have a problem that you want them to follow up on. Let's switch, next slide. This came to my attention today a couple of times. It's been in the news. Deb and I picked up on this late last week. But there's an awful lot of confusion about these darn Chinese KN95s. Are they good? Are they not good? Can we use them? Can we not use them? And you heard last week David Zimba talking about this in terms of his tests. Yeah, they were able to do the fit test, but they didn't do well on the qualitative when they put it on the probe machine. But we're getting to the point now where we've got hospitals, as you all I'm sure are experiencing, that are getting down to the point where they're down into the days left of N95 masks, and some are issuing N95s and are expecting your people to wear it either all day, or in some cases I've heard stories about where they take it off, put it in a bag, and they try to sterilize it under a UV light or with something and put it on the next day, and they might wear it for a week. So I thought I would share this. There has been some guidance that's come out. The FDA realized that maybe they need to be a little more flexible on the KN95, which is the Chinese version of our N95 mask. And so last week they changed their position and issued some revised guidance. I've got the links that you'll be able to get on the material you'll download to their new guidance that came out that indicates that they do, if you have exhausted all other avenues and resources, you do have the ability to use the KN95 as a substitute for a NIOSH approved N95 if you need to. They also apparently didn't include it in some of the CDC listings, and so they've again got another reference site where you can look at that. Some of this has to do with respiratory strategies in short supply, 3 different tiers, normal, contingency, and when you're at that crisis point. So you'll see that has now been added or can be included in that. When you get into that last resort, you run out of other options, it's better than a bandana. I think you heard us say that last week.
About 1 minute.
This has been an issue because a number of suppliers have been hesitant of whether to ship these or not. Are they real? Are they not real? I don't know. So hope this helps. Let's go on and take a look at that third slide. And I don't have all the details right now, but I will tell you that Robbie Hume, who's the branch manager for the Kentucky Public Health Preparedness Branch, let us know that they are in the process of updating and revising the process that they're going to be using to request materials from their various caches and stockpiles. A lot of the stuff that we had purchased over the years from previous pandemics has pretty well been burned through, and they're replenishing it with things that they are buying. Kentucky Emergency Management is doing a lot of vetting with some of the other state agencies to try to make sure they're getting good materials in here, and they're buying a lot of stuff, and they're working now in tandem to the Kentucky Emergency Management process. So what they're going to do, we started out with this, we moved off into a different process for healthcare. We're going through our regional coordinators. They're now beginning to look at refining that process, since more things are in that cache and in that stock of materials than just PPE. They're going to go back to a form, I understand, that'll be on Web EOC again. You'll put it in there as a resource request. It'll be then pulled down, prioritized, and reviewed by a state group. If it's medical, my understanding is they're going to have a group of physicians and medical personnel participate in the review and prioritization. You may also be asked, and some of these facility folks are being asked right now to put in information on how much PPE, what type have you got, how much have you got on hand, what's your average consumption, burn rate, how many days you've got, and so forth. Unfortunately, this is a requirement that's beginning to come down not only through the state, but the federal government is looking at this so that they know how to allocate their own assets and resources between and among the states and hotspots across the country. Likewise, we're being asked to provide for those who want ventilators from the federal stockpile, similar kinds of questions about the number of vents that you've got, how many are in use, have you done any pairing or splitting of the vents, have you done any modifications of your anesthesia machines, and things of that nature. So they're beginning to probe this, and it's all part of their process of trying to figure out how to allocate scarce resources in these times. So Just a couple of things I thought I'd share that were hot, some of which have just come in within the last half hour or so that I've put along here. Just make sure that you're up to date.
Thank you, Dick, for that.
I'll be online and we'll take questions when we get to that point.
Yeah, thank you, Dick, for that very timely and hot topic items. Now, transitioning over to more of a focused facilities perspective, we're starting with Ron Henley from Baptist Health Paducah. The next two sections from Ron and Andy are going to be covering more facilities hot topics. There's a lot of hot topics out there. We know we can't cover them all, but we picked a couple of hot topics to touch on. I do want to say as kind of a disclaimer that remember what we're doing with these hot topics and with our question afterwards, this is informational. We're sharing information back and forth. We know that we're not going to be spot on with every nuance, regulatory compliance and regulation going on out there. So we just hope that in the light of our fellowship of KSHE, that we can have these open conversations and learn from each other actively while things are happening. So Ron Henley, go ahead.
Thank you, Mike.
Sorry about that.
So good morning, and hope your day's going well and you're getting some downtime, and most of you likely have worked 10, 12 hours a day and many days in a row. I will say I appreciate your efforts. So let's get into the air filtration. Now I've heard some stories about some quick solutions and some people creating, so we'll call them so-called isolation rooms, but let's first look at what we're dealing with, and that is the size of the coronavirus itself, at a 0.06 or 0.14 microns. If you remember, the N95 mask, is a 0.3. And most of all our filters will not do that size. It wouldn't capture that size particle. So it's helpful to understand that, but the saving grace to this issue is that particle is attached to sputum, or more commonly known as mucus. It's only by virtue of that we're able to capture most of these particles in our filters. So next slide, please. So it helps to understand the survivability of the virus on different surfaces and when it's aerolized, and that's what we're talking about now, is when it's aerolized. But it also of note there on that slide is that virus can live longer at lower temperatures, although the warm weather will help this, but it will not eliminate it. It just shortens the time that it can survive. Next slide, please. So there are many.
Sorry about that.
Yeah, there you go. Yeah, so there's a lot of charts like this out there, and they're readily available, but it helps you from the facility perspective understand that, for sanitizing surfaces and time frames. But of note on there is water. I don't think we mentioned that very much, but water, it apparently doesn't survive in water. So that's good to know. So next slide. Yeah, so now really on this slide, what I want you to take away is, how long that particle can remain suspended in the air, and that really goes to our air filtration concerns. Next slide. Yeah, so talk about social distancing, and mentioning that aerolization, it can suspend in the air for up to 3 hours is what I'm reading, and this graphic should be kind of telling. That's your 6-foot distance, and the different color particles are different size and weight. So as you're talking to somebody and they're infected, as this slide shows you, you can see with that cone, how that, if you're not protected, wearing a mask, you could be infected very easily even with that 6-foot distance. That's why social distancing and remaining at home, is so vital for this whole situation. So, next slide, please. So this slide is one each of the engineers probably know by heart already, but it's the two filter banks, the 7 and the 14 MERV rating. We have to equate to, let's go to the next slide. So here's your 7 and your 14. So the 7 you'll see at the bottom of the graph there is the micron size. So it's around the 12, 10 to 12 is what that MERV rating, your first filter bank, is capturing. And your second one, the MERV 14, is now down to around 0.5, 0.6, 0.7, somewhere in that range. Now, if you, like I said, recall what the size of that particles, are of the virus. And by virtue of this filter alone, you would not capture, it would pass right through, but only because of the attachment to the carrier that, that these filters are beneficial, but remember the efficiency of these filters is what you got to think about. The MERV 14, it's captured maybe 90%, so you still got particles sliding through that filter, not being captured. So that's the concern. There's no 100% filter out there, and that's what you got to keep in mind. Is it's not 100%. We're capturing a percentage of. So let's go to the next slide, please. Yeah. So and I put this in there so you'll have it, as whenever you want to look at it. But it looks at the air exchange rates, and that's why we're kind of talking about some areas in your hospital have very low air exchange rates. So that survivability of that particles just floating around, if the air is not getting circulated, the potential for exposure is greater in areas that have less circulation. Let's go to the next slide. So one filter, and likely most of us, me included, do not have these filters in place, but they're available. I mean, they are pricey, but the Ultra, you see it as 99.999% efficient at a 0.1 micron size. That's actually a filter would be highly beneficial, but first you got to check your pressure drops and then the air exchange rates before you could utilize that. But I just wanted you to know that was out there as an option. So and last slide. Well, no, it's not the last one. It's almost last. But on this slide, if you look at C, and under C, it talks about, and this is what I've done in about 50 rooms at my hospital, is taking out the window, put it's actually a piece of plywood hole cut in it with a HEPA filter unit in the room to scrub the air, and trying to position that HEPA unit towards the patient's breathing zone, and pulling that out and through the HEPA filter, and kind of following this letter C here, directly putting the air outside. And if there's anybody outside of these rooms, that's why we're using the HEPA filter there, kind of scrub the air, trying to protect others outside. And next slide. I'm sure many of you have seen this chart as well. So just marry this chart up to your air exchange rates that are required for a given location, and this is the wait time that should be utilized after the patient leaves the room. Some of this really, if you still doing, and we're not supposed to be doing elective surgeries, but if you have several surgeries in a row, this does prolong the time between surgeries, which is important. Or once we get to the height or peak of this bell curve and having patients in here, if we got some turnover issues, but you only got so many rooms that you can use, and the patient passes away, and you got or they leave the room, and you got to wait this long, it does make a difference. So it's good to know that wait time between positive patients in a given room. And next slide. And this is the last slide here. I included it because it is a pretty good study of the surfaces and aerosolization. So I'll just let you look at that all these slides are going to be available to you. So you mark me down, Mike, as these are open for anybody to utilize.
Thank you, Ron.
But yes, sir.
All right, very good. One more slide.
Yep, that's it.
All right, Ron, I appreciate that. Thank you again for a lot of great information that we'll be providing to everybody. And again, we're starting to we pulled this together pretty quickly with a lot of information. We'll fine tune this based upon the conversation we have with you and, based on what's happening around the industry. We have now Andy Woommavovah, who is going to be speaking about another hot topic. Andy's from Common Spirit Health. Go ahead, Andy.
Hey, good afternoon, everyone. First, I'd just like to thank you for your time today. Thanks for those that are supporting this event. And wow, what a moment in history we're going through these last few months and future couple months. We're being forced to think differently about the way we do things. We're being forced to kind of think outside the box on how we provide healthy environments for those that are seeking care in the hospitals. They're infected with this invisible killer. And some of the things, before I get into what I want to talk about, I just wanted to state that some of the key successes or ingredients for success are healthy relationships with all of the different departments within the hospital. And for facilities, we've really had to take advantage of these relationships, especially with respiratory, with imaging, with our understanding of how all of the different incident commands are being ran across the enterprise. And then Deb said it. She said rapidly evolving. Every day something changes that we have to react to. And when Mike and the team asked me to talk about, a facility's hot topic, it was like, oh my gosh, where do I start? Because like I said, every day's different. But one of the things that we have been planning for the last couple of weeks in earnest are our surge planning for our hospitals. So in Common Spirit Health, we have about 115 hospitals over 21 states. And then each state is kind of governed a little bit differently. So we're having to be very flexible in the way we are planning our surge. But one of the things that came up, and some of the folks on the call today talked about ventilators, anesthesia machines. Oh my gosh, me and my team have learned more about ventilators in the last 2 weeks than we ever thought we would. If we go to the next slide, Mike. So the hot topic that I just picked today was to talk about medical air systems. So I spoke about the surge planning, and we really need to know the max capacities of our infrastructure of medical air before we start plugging all these devices into, the head walls. And this is where relationships with RT comes in. And what I wanted to do today is just talk about some points to guide us in what we're doing and how we're doing it. And I am by no means an expert on this, but some of you all may recall that KSHE has established the COVID-19 Business Partners Resource Roundup Digest. And this is where a lot of this valuable information comes from. We don't take it, that this is the end all be all. We do reference some of this stuff, but as for general guidance, this has been a very good resource for us to get some quick research done and be able to get some information going fairly quickly. So one of the things I want to talk about is some of the highlights of this. And when you're deciding on areas to use for ventilators, you want to pick the zones that have the largest pipe size. I'm going to talk a little bit about how we're assessing that in a couple of slides, but your respiratory therapist along with your facility engineers will more than likely know this. If they don't, some pretty robust research is going to have to be done in the hospitals to understand that. Next slide, Mike. So I'm just going to go through about 5 or 6 of these highlights. You want to find out, what your maximum continuous flow is and your lowest operating pressure for the ventilators. Like I said, we've learned more about ventilators and how they operate and the different types of ventilators. We've set through training on how to convert the anesthesia machines to ventilators just so we understand what it takes to operate those. And number 2 there, you want to know what your main line pressures are currently set. For your O2 and your medical air. Sometimes your facility folks manage this directly, but there's recommendations that we want to make sure that the pressure is maxed up at 55 PSIG, and this is all governed through NFPA 99. You want to make sure that your bulk O2 provider is in sync with you when you're doing these assessments, and more often than not, they can come in and help you complete the assessments of your total capacities of your systems. By setting these pressures up, you've got to let folks know that you can encounter some additional alarms with the system. So you might have to do some recalibration. And then when you're looking at your medical air system, you want to make sure that you have backup capabilities for that. I'm going to walk through some potential challenges with some of the air dryers here in just a little bit, but that's all very important for you to assess. Your engineers need to make sure that their PMs are updated, or just run through and do PMs again. But as you start to work through this, there's going to be some devoted folks monitoring this equipment hour by hour. If you, God forbid, you have to get into a surge scenario. Mike, let's go to the next slide, please. So as part of the assessment, and your RTs are probably already tracking this, you need to identify areas where you can start to backfill your system and have your certain type cylinders on hand to be able to do this. And then sometimes the unforgotten item is your emergency oxygen supply connection. You need to exercise your plan for utilizing that. What we found is we didn't have the right fittings to connect to it. Some of the hospitals thought they had them identified. Some of them thought they came on the truck. But now we have boxes that have all the connectors that will be able to connect the bulk suppliers that come in to service that connection on hand. If you haven't tested that in the last 3 years, you want to do that. More often than not, it's on a PM somewhere. So just verify that and pull it back up and test through that. As you're working through this, you want to make sure that you have someone monitoring your bulk oxygen. The vaporizers can ice up, and you don't want that to happen. Some of the icing is typical, potentially like a quarter to a third of it, but it's got to be monitored daily, and then your bulk oxygen providers can give solutions to help manage that if they start to freeze up. Let's go to the next slide, please. So I highlighted earlier some risk involved with air dryers with your medical air compressors. So we did have some of this happen in the past where the air dryers failed and pushed moisture into the line and got into the ventilators and took the ventilators down. So you want to make sure that folks are monitoring your medical gas compressors. So what happens is if the room ambient temperature exceeds 98 degrees, your equipment will start to overheat. So it can be something as simple as putting a couple of fans on that and monitoring those and including those in some of your rounding. Now, what we've had to do is in some of our hospitals, we didn't have a good idea of the size of our medical air lines and O2 lines. So we had to develop a plan to go in and do a physical assessment. I spoke to this a little bit about this on the very first slide, but if we can go to the next slide, please, Mike. And this is where we teamed with SSR, one of our engineering partners, to help us work through doing the analysis. So they have set up a central email address, and this particular data sheet went out to all of our hospitals, and they're gathering this information and sending it to the central email address. And what SSR is doing is they're doing an evaluation and providing a information sheet back to the hospital on, based on pressures, the number of ventilators that can be put into each of the systems or the zones based on the line size. If the last thing that I would like to say, and this is very important, is to be able to memorialize this data that you're gathering. And one of the things that we've done is we've teamed with our CMMS provider, Facility One Technologies out of Louisville, to establish some additional asset IDs where we can put in the rooms and on the floors to capture this specific information, be able to memorialize that. So God forbid we go through this again, we have this relevant information, we update it for new space, and then we're able to provide solid guidance to our healthcare providers. Mike, I believe that was my last slide.
Yes, it is. Well, thank you so much, Andy. And again, the information today, I'm just amazed at how quickly we were able to pull this together for a benefit for you, our KSHE members, and others that are attending today. I want to thank Joe and Deb and Rich and Ron and Andy for their time. I know that I think already Deb and Joe and I think Rich maybe had to leave already because of the pressures of the job right now. I know that Ron and Andy are planning on staying around for a little bit for our Q&A session here. We hope you have questions for us. We hope that you help drive future topics. It's our goal to continue to do this each week. I really loved what Andy had to say about memorializing this information. I talk a lot about the idea how we need to take more and increasing ownership of our buildings. And this is a great opportunity to do both those things: gather information, create better inventories, take more ownership and knowledge of our buildings. So it's been a tremendous opportunity. On one hand, it's been devastating for so many. On the other hand, when there's things like this going on, there's great opportunities for us in our profession. So what we're going to do is, I know that Emma and I are going to monitor the Q&A section. I'm going to let Emma go through how to submit questions again. And so Emma, if you could please share that, and then we'll sit by for a few minutes and wait for any questions that might come through.
Thanks so much, Mike. So at this time, if you have any questions, please do drop them in that Q&A box. Once again, if you don't see the Q&A box, you can hover your mouse over the middle of your screen. You'll see a toolbar either at the top or the bottom with a nice button that you can click to bring it up. So you're welcome to type in your questions there. We'll go ahead and hold for a moment to give folks time to type, and then we will jump in.
And I'm going to flash back to our sponsors page during the Q&A session, since they've been so gracious to support us. Apologize for all the flipping through. Again,
Hey, Mike.
Yeah, go ahead, Andy. Yes.
Hey, this is Andy. So, hey, I know that one of our vendor partners is on the line, and I don't know if Clay, if I'm going to put you on the spot, but if you don't mind, if you could share any other lessons learned related to kind of O2 assessments out there that SSR has been encountering.
Now, is Clay actually on the presenter line?
I've given him permission to talk.
Yep.
Okay, gotcha. While Clay's getting on, I'm going to just mention, I know that Joe Taylor and I spoke about the 1135 waiver from ASHE put together last week or so. And then also it was mentioned that the Joint Commission is submitted for all Joint Commission hospitals, 1135 waiver for deference of inspections to the CMMS for adoption for all Joint Commission hospitals. I believe it's on the Joint Commission website. I did try to find it earlier. I didn't find it in time. If you do know about that and you want to submit it to us, we can send it out. I'll continue to look for that. But it's my understanding that that has been submitted to the by the Joint Commission to CMMS. Clay, are you there? All right, are we having some problems with some audio here, Andy or Emma?
Don't know. It looks like it shows him being on mute, so there may be some. There he goes.
Now, can you hear me?
We can.
There you are.
Loud and clear.
All right. Thank you very much. Yeah, the Andy, good information. That was all spot on. The only thing that I would add is that we have had some discussion with several owners about the capacity of the bulk oxygen evaporators. Liquid oxygen obviously has to evaporate, which absorbs a tremendous amount of heat in order to do so. And you all know the ice forming on the fins at the evaporator. Those evaporators are sized for a nominal load, as you can well imagine, and in a surge situation, obviously we're using much more oxygen than normal. With the weather being warmer, there will be more available heat ambient heat available to the evaporator. But I've heard there are other ways, either spraying water on the evaporator. You don't want to evaporate it too fast because you don't want to slug the vapor lines with liquid oxygen. But certainly consult with your oxygen provider. But a weak link in the chain several times already has been identified as that evaporator out at the bulk tank, and making sure that it's up to the increased flow that we're all seeing.
Hey, thanks a lot, Clay.
Oh, thank you, Clay. I appreciate that. Emma,
Yeah.
do you have any other questions?
I think we're good on questions. And folks, if you do have questions after the webinar, you are of course welcome to email them into KSHE directly at info@kshe.org, KSHE. A couple of our presenters have been kind enough to share their email addresses, in which case they're happy to speak with you directly as well.
Again, and feel free to send those again. You can send those to me as well. I'm going to try to be the coordinator of information. And again, we hope to do this weekly. So this is our first offering. I really just impressed with just how well we're able to pull this together at such short notice with these experts. And I just, again, appreciate their time, their effort, their sacrifice. We also do understand that, you know, we may not all be able to be here every Thursday, so we may have to adjust the schedule a little bit. And if necessary, we'll try to bring some additional experts in when topics, you know, render it so. So again, we do appreciate your time today. We hope that you have a great day, and we look forward to flattening of the curve and getting to the backside of this thing this season. Anybody else have anything else to say before we close on the panel?
No, Mike, I appreciate the time. This is Andy, and you can absolutely share the information that I provided today.
Awesome. Thank you very much. Ron?
No, we're good to go, and I hope everybody has a great day.
Okay, I don't know, Richard, Deb, and Joe, I think you're gone. Any one of you three there?
No, I'm still here. I have forwarded to Emmett and Mike the information that just came out about 10 minutes ago from the state on their new process and procedure for requesting supplies and materials provided to them so they can post it on the KSHE site, so you guys can take a look at that and understand how the process works. There is some regular PPE reporting that's involved, and it's all described in the 2-page attachment that you'll see when you open that up.
Well, thank you very much, Rob. I appreciate that timely information. And again, we appreciate all of you. This is our first offering. We hope to see many of you and many more. And we hope you found this valuable today. And next Thursday, same time, same place, and hopefully same presenters. We'll see you. We'll see you next week. Thank you so much. Emma, it's yours.
Thank you.
Thanks everyone for joining us. Once again, we will post this webinar and the slides on our website within the next week, so keep an eye out.
All right. Good job, everybody.
Thank you.